this chart, just to give you an idea, we won't go into all the detail, but it'll be available for you. Again, it goes into some of the detail of these sources of focus for compliance plans. Down the left-hand column are all the various contractors or different types of organizations that contract with the federal government in one aspect of healthcare delivery and claim submission, and the interest to avoid payments that are made in error or payments that should not be made due to fraud. And the various programs are described on the left-hand side, what type of claims that they review, how they select claims, the volume of claims that they research, the type of review that's conducted, and the purpose of review. And we are actually starting to see some additional activity by ZPICs on an area that does impact your services, and that is in the certification and recertification area. Some practices are reporting to us that they are receiving sort of educational materials from ZPICs regarding volumes of search and research. And then finally at the bottom there, the OIG, Office of Inspector General. Relating to the Office of Inspector General, each year they put out a work plan, and it used to change in the fall, or be developed and implemented for the fall start. Effective next year, it's going to be on more of a calendar year basis. And this is what influences how the OIG decides what areas to look at across the payment programs with inpatient for hospitals, home health, hospice, your professional services, lab, radiology, etc. These are some of the factors that go into how they develop their work plan. They have mandatory requirements for OIG reviews set forth in laws, regulations, or other directives. Requests are made or concerns raised by Congress, HHS, or OMB. They understand that there's top management and performance challenges facing HHS, and they want to investigate to try to improve program performance itself. They may have work to be performed in collaboration with partner organizations. They may have made decisions to implement, that is HHS and Medicare, Medicaid, et cetera, may have made decisions to implement their recommendations from prior reviews, and then the timeliness of certain topics. Not to go over in detail, but just to give you an idea, this is from sort of the table of contents of Part A and Part B contractor, what will be reviewed this year in the OIG, what is under review this year in the OIG work plan. And again, you can see the various areas that they are looking at. And some areas affect your professional services more than others. The correctional issue is actually in the work plan for this year, where you have received some requests for a recoupment of payments when a beneficiary that you actually saw in the home was thought to be incarcerated, and that information wasn't properly understood by Medicare and also by OIG, and you've received a request for that repayment. So that's an example and where it came from. This continues with more of the issues that the OIG is looking at on a Part A and Part B basis this year. And again, here's the one for the payments for incarcerated beneficiaries. And there are other issues here that will be impacting or may impact your practice and notifications in time. Okay, so we've covered the legal background for a compliance plan and sort of the context. and how the environment is becoming more of a mandatory one for compliance plans from a voluntary one, the benefits of a compliance plan. Now we wanted to move on to some of the more specific elements. And just from a top-down perspective, again, the coding and documentation nomenclature that's used in the roles in coding and payment. Of course, we have the CPT terminology. We have ICD terminology. And to note, ICD-9 is in effect now and through October of next year. October of next year, there will be a transition to ICD-10, and the Academy will provide resources and education and assistance to make that transition successfully, beginning with the Frontiers article that you'll see in the next month or two. And effective services October, dates of service October 2014 and after next year, the ICD-9 codes will not be recognized. ICD-9 and then ICD-10 will be important too, as they feed into the hierarchical condition category scoring methodology, and that's increasingly being used for payments and to influence payments by both public and private payers. And again, we'll provide more resources about ICD-9, 10, and HCC scoring. We've been asked, what is the sample size for conduct of an audit, and is there a certain benchmark that needs to be provided? The OIG compliance plan that we just discussed provides the following. 5 or more randomly selected medical records per federal payer. So if you're a solo practice and just Medicare, then you'd only have to review 5 medical records. If you have more than yourself in your practice, then you'd want it to be 5 per each. If you were seeing both Medicare and Medicaid beneficiaries, you'd want, again, 5 per payer. And then an alternative is 5 to 10 medical records per physician, and that should also be per clinician, nurse practitioner, or physician assistant. And again, that would be established for your baseline, and then at least annually afterwards. My recommendation is that once you put the process into place, that you'd be interested, for reasons we'll see in a moment, in reviewing your documentation, coding, and revenue cycle on a more regular basis. And that's presented here. So it's compliance and tracking and how that leads to practice improvement. This is a table or a tool that I've used in practices and have seen similar in other practices, where you provide by area, by clinician, by data service, by CPT service, diagnostic codes, or practice site that's related to you in your own community, or if you have multiple sites across the country, or by business staff or by payer. You can determine, again, do the sampling of patients that would go down the left-hand side, place your data service in. I like to have the Julian data service added, which day of the year you're at, the CPT codes that you coded the services, the date of entry into your system, the date that the claim was submitted, the date that the payer received it, the date of adjudication, and this is all facilitated these days with in more electronic transactions. The date of explanation of benefit, the date that your practice posted the payment, and then what were those payments by CPT, or what edits or denials did you receive when you sent those services in? And again, that is the opportunity for the feedback loop here. What variance in dollars did that produce, that some services, CPT items, were not paid? And again, this could be by the Medicare program or by contractual relationship with a Medicare Advantage program or Medicaid managed care organization in your state, et cetera. And then on the far right-hand side, what is the total days from the date of service to the posting? And so there you can also have an idea of, again, the revenue cycle and also the matchup of the clinical and administrative sort of throughput. What was the timing that it took from the rendering of service to the payment or the adjustments were posted? And then with this information, as it builds up, you can do a lot of things with this information. You can review to see if you have clinical service, if it's a clinician, if you have clinical service issues, or the administrative service or aspects of their practice and performance, that if it's still in a paper environment, they're not completing records, they're not sending in the records and encounter forms to billing staff, or is the issue with data entry staff themselves, whether that's internal or external. Are issues with revenue cycle staff, internal or external. You can then use this information to, again, see if there's patterns with a payer. Are there, which would then produce a contractual or regulatory issue that by contract they're not paying you in accordance with the agreement, or by regulatory perspective and clean claims provisions, that they're not paying you on a timely basis within your state. So again, this has benefits to your practice in many aspects. Do you have a documentation reporting issue, or again, is this a clinical issue where they're not understanding or receiving the records, or aren't comfortable with what's being submitted for a beneficiary's condition? So what you can do with this is you can reconcile, negotiate, educate, improve. This also provides information to you about scheduling. How busy is that practice? When were those services identified? What services were rendered? And this can also feed into potential for, do you need recruitment of clinical or non-clinical staff? And it can come off of something that's based on this audit function. And then this also provides, again, for relationship opportunities. You can see what services are rendered, what opportunities are there from a clinical perspective, what payment issues you're having, what discussions you need to have, and perhaps some collaborations come out of the services that you identify as a result of this compliance and service and revenue cycle tracking. I want to quickly go over some distribution issues about evaluation and management services, and go over Academy resources and next steps, and then leave time for questions. Evaluation and management code distribution, we were asked questions about, and we do receive information I'll describe in greater detail in a moment. Generally speaking, there's the expectation that there'll be a bell-shaped curve of code distribution, and over time it has been identified that that bell is shifting to the right of the code selection for all specialties. In fact, the OIG provided a report, conducted a report in 2010, coding trends of Medicare E&M services, and here's where the report is found, and that reviewed coding trends of E&M services across specialties from 2001 to 2010. And they found that over that time there was a shift across all sites of service and specialties from lower level codes toward the higher level codes. In that information, determined that the 18 house call evaluation and management codes reflect only 1.6, but it's a growing percentage of all Medicare evaluation and management payment. And we have just received our annual report for 2011 of Medicare house call service volumes and how the coding is distributed across the specialties that make up those that use the house call codes, whether you're internal medicine, family physicians, nurse practitioners, physician assistants, etc. And so we will summarize that information and present that over the next weeks. And again, we've just received that, and that report, due to CMS claim systems, is usually about a year in arrears. What the OIG report found is that there were, in 2010, there were 370 million E&M services were provided by 442,000 physicians, only 3,000 of which had an average E&M code in the top 1% of their specialties. And then of that number, 1,669 were the true outliers, and they were billing the 2 highest level E&M codes within a visit type at least 95% of the time. So we see that even across specialties, there was a very small group of outliers that was identified by the OIG, and they recommended certainly drilling down to identify those physicians who are submitting claims at those high levels, and commented that these physicians substantially differed from others in their billing of E&M codes. Let me finish with this slide for this afternoon in the interest in receiving and taking a look at questions. To assist you, the Academy has recommended clinical guidelines for quality home care medicine. This was part of the field guide and is also a standalone document. The guidelines include a section on ethics and law that covers legal and regulatory issues. And the guidelines are provided now to anyone that joins the Academy. They're available online, and they're also, again, as mentioned, an appendix to the field guide. Other resources available in making home care work in a medical practice, brief guide to reimbursement and regulations that's available online. I mentioned the white paper or document that was developed by the Public Policy and Practice Management Committees, Auditing of Home Care Medicine Practices. We will post, and I can distribute to those on this call, that document that described, that provided an overview of house call practice, the models, and discussed utilization patterns appropriate given the range of models and one's patient population. And again, this could range from more than 1 visit a day to multiple visits in a week based on patient status, to perhaps not needing to see a patient for every few months. And again, the volume of encounters per day ranging by provider and setting anywhere from just a few on almost on a part-time basis, if you will, or intermittent basis, to 15 or 20 encounters a day. And there was that rationale in the paper was provided as background information to Medicare medical directors. The Academy will provide in the future webinars on ICD-9, as mentioned, transition to ICD-10. The care plan itself, we will provide a fraud and abuse primer, a webinar on the developing contractual relationships within practices and with practices in health systems, ACOs, post-acute providers, health plans, etc. And then a webinar on for nurse practitioners and physician assistant, and the unique characteristics and regulatory issues of their practice. As mentioned, there's a compendium of rules and regulations for home care medicine practice that Dr. Gresh Bain has developed over the years. We will update, the existing version will be posted, and we will update as many rules and regulations have changed recently due to some of the major legislation that's come out in recent years. And we will provide that update and hope to have a completed compendium available at the time of the May 2014 annual meeting. And with that also, we will provide you with compliance plan templates with actual language, policies, and procedures, and template language for those 7 areas that we discussed today, on both a small practice basis and also for larger practices. So in terms of questions, are there guidelines for frequency of visit? There are reviews and comparisons regarding frequency of visits, and again, I will provide that summary of the information we just received from Medicare. And I think that the white paper in terms of frequency of visit will help. And we did see in the Medicare guidelines today that they didn't believe that it should be different for the patient's condition that they would receive in any other location of service. So again, not so hard and fast, but again, this to be based on medical justification. Any insight on coding distribution for a typical house call practice? I think the information we've just received, and we will update and also provide a running basis with prior years, will be helpful in terms of coding distribution. Have a specific question about wound care, and I think we'll need to take some of these questions and respond, both post responses and then also respond offline due to their detail. Provider taxonomy make a difference in comparative reporting. As you'll see in the code distribution, it does appear that by specialty there is some differences across specialties, but it's slight. It's not a very big difference between specialties, and I think when we summarize that information and post it, you'll see that information. Should one establish an 800 third-party reporting compliance hotline for a practice? That is one of the recommended ideas in the voluntary compliance plan of the OIG, and so that is a good idea. And also any email or again physical sort of Dropbox mechanisms to report things on an anonymous basis, and for beneficiaries to do the same. Do background check through CMS. We'll provide the information where you can find the list of those. It is on the OIG site, and if it's also, the question was about excluding, encountering or maybe speaking to recruiting someone that may have been excluded without the practice knowing that practice was. How could one find out? So again, we'll post the information where that's available on the OIG and the CMS site. Process improvement aspects of the plan will, future physician compliance plans will require process improvement. Process improvement may come through the coding aspects. For example, the coding aspects that are under development by CMS now. I think the idea is that compliance, as described, can contribute to clinical and administrative improvement and cultural improvement throughout the practice. One way that we will see is in the promulgation of the rules that new providers joining the Medicare program have to have a compliance plan. I think that'll be an opportunity for us to see if process improvement is included in that language. Question is regarding a healthcare home health agency nurse and another practitioner when seeing the patient at home on the same day. Is there a conflict in payment and the benefits of seeing the patients together? What I'd like to do is provide the documentation on that, and again, we'll post that with the greater specificity. But regarding the requirement for a patient record, the question is coming up, can you be the provider of record when there is a physician that had a relationship with the patient, but that provider is no longer seeing the patient, and that patient is, for their home-limited reasons, not able to get to that provider's site of service. Again, I want to research and provide any specific documentation there. It would be the sense gained from looking at the requirements that we reviewed today that going to the place of residence does provide the opportunity where you are the provider doing that to have that, and particularly if it's at the and required to be at the for new patients at the beneficiaries or their caregivers request or some delegated request to be that provider and to document that relationship as that primary care provider for that beneficiary and that location would be acceptable. And again, I will do some further research on that question and then post that for you. When will compliance plan templates be posted? We'll try to develop those between now and over the next few months. I don't want to promise them sooner than we can provide them, but would like to have something available to you as part of that update to the compendium at the beginning or turn of the year. If there's any specific questions or requests for assistance, please give us, please send me an email or give us a call. And the final question has come in, and again, I will post this one as well. Can we bill for miles when we draw labs on the same day as an E&M visit? I think that there is some question about that opportunity, and I will research that and post whatever information that I can find. Again, so I want to thank you for your participation and for your questions today. We see that the the field that we work in, how important it is to have compliance in place and compliance practices in place. Also, the benefits that can accrue to your practice, both for yourself individually and in relationship to payers, et cetera, and then as your practice grows and in your relationship to staff and other parties. So thank you for joining us this afternoon. We'll research these questions and post this information, and again let you know when the posting of that summary valuation and management distribution information and volume information in the field is growing again, continually growing with the Medicare program and others, which is wonderful to see. And we'll also present that white paper that was developed on house calls and utilization as well. Thank you, and have a good afternoon.